I'm a frontline worker, and quite early in the pandemic, I could palpably feel the distress around me, and clearly I felt it as well as a physician, as a wife, because I'm married to another physician and I have 3 children. And the disruption and chaos around us was profound, and everybody was so stressed, and it felt like we were making no progress. And because I'm also a researcher, I kind of thought, you know what, I'm not going to be a guinea pig. I'm not going to let somebody do a study on me when I have the insight to understand what is going on and what we need to measure. And that if we don't measure this right now, we will miss this moment to understand what this crisis has done to this health workforce. This is really important, because if we don't measure it and understand it, we can't change it. So with that chaotic thought process and trying to manage how to talk to my patients, I called Karen, who I have worked with as a researcher for some time, and I said to her, we have to do this. Between us, we have to do this. We just have to make a way for it to happen. And Karen probably just thought, oh, she's nuts again. But we actually do collaborate on an awful lot of things. And so between us, we kind of said, well, we'll just do it. And there was one very frenetic day when I called a whole bunch of my colleagues who were friends, who were heads of departments in different hospitals around Victoria, and said, we have to do this, and I need you on board. And I brought 15 people together overnight, and we put in for a couple of grants, which we were unsuccessful with, but I'm sort of good at persuading them to give me money. So I persuaded our hospital to fund us to do this. And from that, this study arose. And I guess what was interesting was, as we were doing this, you know, the first wave came and went, and I was kind of thinking, oh, done it's dashed, we don't need to do this. And the second wave came. And actually our moment was primed, because we were ready to go. We were the only research group that had frontline workers that was actually ready to do this piece of research at exactly the right time in Victoria. And so from there, this incredible piece of work, that's why we got 9,500 people who responded in 8 weeks, which is incredible from healthcare workers, because I never take surveys. You've got to really persuade me. So people wanted to give us their voices, they wanted their opinions, and that's why the book is incredible, because we've got so much breadth and response. So that's kind of how it works. That's my perspective on it.
Well, I might just add that Natasha's a numbers person, but I'm a words person. And I never thought that we would get, but in total, so this is what you're looking at in the book, is primarily just the answers to one question, but we have 4 free text questions, and we have, I think we've counted about 20,000 responses in free text. And for people, most people will fill the scales out and do demographics, but to actually get them to write, and to write heartfelt words, and is quite amazing. I've been doing qualitative research for a very long time, and I've never seen anything like this, or had a data set so large to try and analyse.
So Marie, how did you get involved?
So I'm a researcher and a frontline clinician as well. So I work in psychiatry, providing mental health care. A lot of my work in the last 2 years has been providing mental health care to patients with COVID on the COVID wards, and people with COVID in the intensive care unit who also have mental health or addiction challenges. So it's been a pretty challenging 2 years, but I also do a lot of research around clinician wellbeing. So I have never met Natasha before. I remember sitting at the hospital one day in the middle of an incredibly busy clinical day, and Natasha called out of the blue and said, this research needs to be done. We know that you're really interested in clinician wellbeing. Would you come on board? And I said I would love to. And then as Karen said, we just never expected the volume of stories that we received. And I was trying to get home to see my family. My husband and my daughter and my parents were all in New Zealand during the pandemic. So I was trying to get home to see them for Christmas, and I had 2 weeks in managed isolation in a hotel. And since I was going to be locked in a small room for 23 and a half hours a day, Karen saw that this was an ideal opportunity to get somebody to read all of these free texts.
Come on, Marie,
responses. I did. So for 2 weeks I was in managed isolation, and I just read these stories, and I had just come off this incredibly intense and at times traumatic and distressing experience of being on these COVID wards myself. And for 2 weeks I sat in this hotel room and I cried, and some of the stories made me laugh, and some of the stories were just so tender, and some were really hopeful. And I thought, well, just can't leave these sitting in a research data set. That, you know, if I've had this profound experience, that they've given voice to some of my experiences, maybe other healthcare workers would feel in the same way. And I thought, in 50 years, if somebody wants to know what it was like for healthcare workers working through the COVID pandemic, we need to have honoured that and witnessed it, and made sure that their stories can be heard. So I said to Karen and Natasha, I don't think this is going to be a peer review paper or even 3 peer review papers. I wonder how you would feel about the idea of a book.
And that's how it happened.
That's how it happened.
So as a qualitative researcher, how is this particular study unique, and from your experience?
Yeah, we were talking about this today, weren't we, and how you don't usually, we had never expected to see such rich responses from a survey. We would usually interview focus groups, but to see paragraphs and paragraphs of really nuanced and complex ideas and experiences expressed in words was, I was really surprised to see that on the page.
Absolutely. And of course, I mean, the other thing is the volume. We wouldn't get qualitative studies that never this big. So that was, I mean, quite profound to get such a huge volume.
And I think the vulnerability, some of the quotes that resonate with me the most are from senior male doctors who talk about crying on their way to work. And I've been a doctor for a long time, and I've never heard a senior male doctor talk about crying on their way to work. And so there was that honesty and that trust in us and researchers, that people were willing to make themselves very vulnerable. And the number of people who said, I've never spoken about this before, nobody's ever asked me about these experiences. And one health worker said, I haven't felt able to talk to anyone about this. My friends, my family, even other doctors, they don't understand what I've been through. I've been so alone with these experiences because nobody else knows what it's been like for me as a doctor working on these aged care wards with so many people dying. And so there was a real opening up, I think, and it felt like a tremendous gift that people would trust us with that. And I think the sense that we had to honour what they had given us.
So one of the things that really struck me with reading this was that for a number of people, the telling of the story and them expressing what they've been through was a therapy for them in itself. So they said that they felt like they felt better after telling the story. So even, as you said, many of them either hadn't had the opportunity or didn't want to burden others, or for whatever reason hadn't expressed how they were really feeling, but being given that opportunity was a therapeutic response. So obviously this outpouring of emotion and grief and fear and all the experiences that are in here is a result of a crisis. So the pandemic has been a crisis, one that for most of us alive, we've never experienced anything like that. And for me reading this, I think, what are we going to take away from this? What can we learn from this? What change needs to happen? So I'd love to hear from each of you, from as your reading and your reflection, what you think, and I think in the introduction you talk very much about a system that was already under stress.
That's right.
And already needed, there were things that were known that needed to change, and then there's the things that have emerged that need to change.
So I think one of the people who told us their story said that the pandemic has shown up all of the cracks. That none of the problems that have arisen during the pandemic were new, that it was really an exacerbation of pre-existing problems. And so for many of us in the health workers, issues like the casualisation of the nursing force, the extent to which nurses are underpaid and undervalued, the extent to which junior doctors are overworked and working these huge and unsafe hours, problems with really antiquated technology, the fact that in 2022 we're still using fax machines to communicate. All of these problems were pre-existing, but then when the pandemic came, these cracks opened to the point to which they were really these gaping chasms and just couldn't be ignored any longer.
The people who work in the health system are not dupes, they see it too. And they see, they are the best placed people to be able to tell us what needs to happen. And I think what they really pointed to in the survey and in the study overall was the fact that we need more than just fixing individuals. We don't need to make people more resilient. We actually don't. They're very resilient. But we actually need to do some things about making this an occupational health issue. And so the next stage is actually taking what they told us in all the free text questions, and we've been funded by the Women's Charitable Foundation so Natasha and Marie and I on this particular study to actually look at two really important parts of helping to address the issues that were raised. And one is actually looking at leadership and looking at what leaders need and want and how we support leaders and how they manage during this and other crises, because there will be other crises. And then working with healthcare workers to co-design the solutions that they want. So there's kind of two phases. And really our job, because the data will come easily for this project, our job is to kind of look at what's feasible, what can we actually say to healthcare organisations that are massive organisations and structurally really difficult to change. What are the bits that we could say, well, this is feasible. These are the things that perhaps you could try and do. And we've got already a lot of great information from one of the other free text questions which we're analysing in more detail to inform the co-design process. So I don't know, Natasha, can you talk more about that?
Mine just actually touch back to the previous question, because I think the other thing that comes out, so there's this huge element around leadership, and obviously that's an area that we want to explore more, but what comes out very clearly in the survey is failure of leadership, and that came across at every single level. So these healthcare workers felt there was no visible leadership from the senior executive. They thought it was highly absent, and some of the department heads of department headed for the hills, particularly because they were older and felt that they were more vulnerable. So the workers on the floor felt completely neglected, and actually wrote that they thought they were cannon fodder. And that matters because that workforce then said, you know what, why should I take it? I'm not going to put myself at risk. And actually talked quite a lot about leaving the workforce. And I think that there's some really important messages around, you can only do so much to people before they'll say they've had enough, and they do leave. And there's data from the SARS epidemic in Canada where the workforce that was stressed actually left. And there's data from the US recently that shows a lot of the physician workforce has moved as well because of the stress. So we sort of run the health service, and I'm British, I've worked in the NHS. We run the health service on good love and goodwill. But actually people won't take that anymore, particularly the current generation of junior doctors and nurses, they won't take it. And so we really have to learn from the results of the study and say, we have to invest in our health system and take a very long-term approach, because people will leave the workforce. And I think, people really talked about that there was no acknowledgement of the stress they were under. In fact, I gave a talk last week and someone said to me, I'm so angry that nobody has ever apologised to me. What's happened? People are still carrying that anger from 2 years of this and just want acknowledgement and apology. It's amazing how much that makes a difference. They wanted people to do something, but they actually did not want things that they thought that were inauthentic. So, we got quotes around chocolate frogs. I'm worth a little more than a chocolate frog. I now give this talk as I'm worth more than a chocolate frog, because I think I am. But these workers did as well. So, we have to learn from that message. And just going back to this point of leadership, most medical leaders have never done any leadership training. They are technical experts. I have done a leadership course, I'm doing another one, and it opens my eyes to go, oh my God, why have none of my colleagues done this? They're all technical experts, I think they're marvellous, but actually you cannot be a research expert, a technical expert, and actually a medical leader. And until we have leaders who are trained to be leaders and are supported and understand the results that come out of work like this, nothing will change. So actually, this piece of work that we're doing around leadership is key, but we leadership into health education curriculum so that we can actually train the workforce for the future to understand what their role is when they are leading, and so they don't feel vulnerable and head to the hills and leave the workforce as Karen Willis.
It's fantastic, and it's so often the case in any crisis. It's leadership either steps up, and that's what people notice, and that's what makes the difference. People enables them to get through it, or they back away, disappear, and it's chaos, and it's so disheartening. It adds to the burnout and that feeling of being alone in the struggle. So
it's lovely to read the reflections on good leadership as
yes,
well.
I was going to say there's
some nurses and people who felt that their manager had their back and that their manager was in there with them.
Yes.
And that was just so important. You know, one nurse working in the intensive care unit spoke about her nurse unit manager coming past the window outside an isolation room where she was caring for a COVID patient and just giving her the thumbs up through the window, and how much that one tiny gesture made her feel seen and valued and appreciated.
So it's just that's a great example of just how important that leadership is. But as you say, Natasha, generally speaking, health professionals don't get that full training and health support. Some people innately have it, but it's certainly something for most of us that we have to learn. So that's fantastic that you're doing this new study on that. My understanding of translating research into practice is that on average it takes about 17 years. So how can we speed this up?
We could get rid of the fax machines to start with. That would make me really happy.
Yeah, that's unbelievable when I read that. Especially I forgot how to use one.
I mean, I guess one of the things we're trying to do is to engage with leaders now, because the experience is also fresh for them.
Yes.
And so we've got project advisory group, because they're the people who are likely to be the implementers. And this is very practice-based research. So, as a health sociologist, I do say, the health system, having a broken health system's been great for my career, but it's not so great to have it, full of workers in the system. It's profound, but I think there are things that people can do to make the workplaces more humane, to recognise that this is an occupational health issue, and the mental health of the workers in the system is
now law.
And we need to be attentive to that, and we need to do more. Some people do want the individually focused responses, so that when health services do that, but we actually have to look at the structural components. And so I think trying to bring key leaders along with us, even to change learning policies that's a very powerful thing. So to look at things that can be done, yes.
The issue of self-care is something that Sophie's done a lot of wonderful work and really deep thinking about to try and shift the narrative of self-care from something that, somehow deficient health practitioners are supposed to self-care themselves back into being more resilient people, and really thinking of that self-care as being very embodied within your relationships and within your organisation and within your interactions with other people. So I don't know if you wanted to speak a little bit.
I think I heard someone say that this collectively traumatise people, and if we continue to go down the path of trying to build individual resilience, we're never going to get very far. There are things that people told us in the study that would help them. For example, if they were part of a team where the culture was really caring, and they looked after each other, they debriefed and checked in with each other, that made an absolute world of difference versus teams which were, disparaging or not allowing space to talk about feelings which were both positive and negative. So there was a sense that we were being pushed to try to be positive and try to be resilient when we really just wanted space to talk about how we were feeling with each other and given that space.
And what a difference that made for those teams that did enable that. Yes. This might be a good chance. There's a lot of leaders in the room. Has anyone got a question or comment just on the whole question?
I'd like to make a comment to say thank you. Like having worked in people and culture in a big public hospital, and it's very emotional hearing all of this because it's still quite raw. And I think one of the things that we really achieved was breaking down the silos between clinical and non-clinical and working together, and learning about leadership and getting the clinical people to kind of go they'd be like, oh God, Megan, I've never really had time to invest in leadership, and I want to be a leader, but I've never had time to practice on that. How do I make that happen now? And they leaned into it, and they were amazing, and they weren't. Oh, it was just, I really felt like it broke down the silos basically, and then to be able to share a space where they'd be able to come in and go, I want to cry right now. And I'd be like, well, I'm going to cry too, so let's cry together, right? And I felt like it really joined up something that I think, you were talking about how it's always been clinical, non-clinical, like these silos in workplaces in public health. And I feel like we've got this real opportunity now to leverage off that and break it down and work together. So it's like, thank you for, pulling it all together, because I know in people and culture how hard it is to get people to take the time to write and talk about their experiences.
We know for systems change to happen, there has to be a burning platform.
Yeah, there does.
There has to be a burning platform, and really something for people to rally around. This is the change we want to make. And I think there's so much to be learned from the information you gather, the stories and the experiences, and it's really then focusing that so that the change does happen.
As Karen mentioned, Natasha's a real numbers person, and so a real strength is that the book is also complemented by these peer-reviewed scientific papers which actually quantify the level of distress. And I've always thought that the quantitative research is the skeleton and the bones, and that the qualitative research puts the flesh on the bones, and that you need both. You need the numbers and the stories to drive change. So one of the quantitative papers was we found that 1 in 10 health practitioners had thoughts of self-harm or suicide in the 2 weeks before they statistic. And then you also have the stories in this book of people saying, I would have jumped out the window of my apartment except that the window wouldn't open. You hear these really heartbreaking stories, but also the quantitative research to back them up.
And the other thing that jumped out at me was that the number of people talking about burnout and the experiences of burnout, and it was not just as a result of the pandemic, but it was already a feature of the workplace. And we know that burnout is a workplace issue, and it is very much something, a failure of management to provide a safe workplace. So there's work to be done for sure, and that burning platform, I hope, becomes the lever to really push change.
But two things that actually haven't come up that I think are really critical and that need to be acknowledged are, one, gender discrimination has got worse as a result of the pandemic. That comes out extremely clearly in the study, and in fact would never have come out through our quantitative research if we hadn't had the qualitative side. And it's particularly relevant given that last week was International Women's Day that we take that focus into our lens. So there are so many stories of women of all different disciplines and roles and seniority saying the gender divide has just massively increased. I'm not visible, I'm given these appalling roles, whereas typically the white male leader is held up and gets all the glory, and I'm being pushed to one side. So again, we have to acknowledge that gender bias gets worse during a crisis. We have to be proactive in addressing that, because more than 50% of the workforce is women. In fact, 70 to 80% is women because of women being, the nursing and allied health roles being put on for women. So if we ignore that, we're ignoring 80% of the health workforce who has actually profound skills and can contribute. So gender bias is really important. The other thing I just want to talk about is burnout, because the reason women get more burnout, and this comes from data from the UK, is that on the average, women do an extra 11 hours of unpaid work at home. And if there's one thing I regret, we didn't ask about unpaid hours at home, because you can only ask people standard questions when they get annoyed at you. So I really had to balance that when I signed the survey quantitatively. But we know that it's an extra 11 hours. I had 3 children homeschooling in a respiratory position, so I'm like everybody else who had to manage that. And that is a real risk for the female members of the workforce, and yet we don't actually take that into consideration an awful lot. And the other thing around burnout is, yes, it's wonderful, we've got technology and we can do telehealth and we have email, but frankly, I get sent emails in the middle of the night. I'm sick of having emails at midnight thinking, what were you doing? You know, all across the weekend. And I'm just as guilty because I work 6 days a week doing a lot of research and other bits and pieces. And, you know, you increasingly start to see on people's email signatures saying, I work strange hours, it doesn't mean I expect you to. But actually, you know, telehealth at home, patients calling us at home, all this stuff, actually, where is the work-life divide? The balance is gone. So in embracing technology in this new world, we actually need to put some safeguards in because we're only going to make it worse for the workforce. And again, the workforce then says, I'm had enough, I'm out of here. So I think they're just important points that we haven't really touched on.
And a very big leadership challenge to set those boundaries, and you know that will require great leadership to really give permission for people to be able to have their own space and their own time to recover.
And I think once people have that severe burnout or really clinically significant levels of psychological distress, the services that are available to healthcare workers are not meeting their needs. You know, we saw how few of these healthcare workers were accessing employee assistance programs. They were getting emails every week telling them to call the employee assistance programs. You know, and there's a chapter in the book, you know, for people saying it just felt like another thing to do on my to-do list. I was exhausted. I knew that I needed help. I was having suicidal thoughts. I wasn't coping, and trying to find someone who could help me, who was available during hours when I wasn't working, someone who understood my experience of being a healthcare worker. It just felt too hard. And we've seen some amazing initiatives. So a young psychiatry registrar, Tani Bridson, set up a peer support network called Hand in Hand, which is now a national peer support network for healthcare workers. But she's done all of that as a volunteer, you know, on the smell of an oily rag, trying to pull volunteers in to speak to distressed healthcare workers in the middle of the night. And I think we really need to think about funding health services for health practitioners that meet their needs, are available when they need them, and are staffed by people who really understand the challenges of being a health worker.
I'd like to start on that point, Marie. We have Patrick Johnson in the room who I invited, and Patrick is the medical director for the Victorian Doctors Health Programme.
Oh, wonderful.
And I will declare my conflict of interest because I'm a board director for VDHP now, and doing all this work on the survey is why I decided that I would actually step up and offer to be on that board. But, you know, I've lived in this country for 20 years, but I trained overseas and I worked overseas, and I didn't even know that that program exists. And in fact, a lot of doctors don't know what exists, and most health professionals actually don't know. And also the funny thing is, sometimes those programs become quite stigmatised. You think, well, that's where naughty doctors go, so I'm not going there. So I'm not guilty, I'm just stressed. And so we do see that people know something exists but think that's not for me. And so having initiatives that are actually desired by the workforce are quite critical, because again, one of the things that kind of raised a bit at the start of the pandemic was, here, have an app. Here's a wellbeing app, go meditate. And you know, for some people that's great. So about 10 to 12% of people in our survey loved the app, you know, and a lot were developed. But for a lot of them, they said, well, thanks, but that's really tokenistic. I really want to talk to someone, and I want that person to listen to me. So I think, you know, peer support, debriefing are absolutely critical, and we need to be innovative, but not just rely on sort of simplified measures like apps, not things.
The thing that I would add that comes out really strongly out of the data is the need to be proactive, because all that help seeking is putting the onus back on the individual. To when you're stressed, burnt out, you know, here's, you know, all the supports are here, you just need to go and get that. That's the last thing. And so being proactive, and the stuff around leadership, like checking in. I think, gosh, I mean, can't remember how many times is checking in and being visible mentioned throughout the comments. It's really, really checking in and having the authentic supports in place.
And it's not that hard to do once you know it. No. But I think for leaders to know how important it is and what a difference that can make could be a game changer. Look, I think we could talk about this all night, but I'm very conscious you're all standing on your feet. So maybe just one final comment from each of you as we wrap up. Maybe just the thing that you take home message, or the thing that struck you as being, I guess, the most influential after reading all
There
this.
was the idea that this is not the last crisis that we're going to face, and that there are bigger crises coming, like climate change, and that we owe it to our children and to the next generation of nursing students and medical students to have a healthcare system that's ready for those next crises that are coming.
I think you stole my answer. For me, I think it's thinking about the hierarchies that exist in the healthcare system. And when I read the deeply traumatised voice of a senior doctor, all I can think about is, what about the rest of the workers? This is supposed to be somebody who's in a position higher in the hierarchy, and that speaks volumes to me about all the other healthcare workers.
I guess for me, it's again probably the being seen. Like that was the thing that struck me the most: is being seen, being valued, and being recognised. It just kept coming out that this
That everybody needs
being
it.
invisible, feeling that you were forgotten about, particularly after all the public support kind of subsided as time went on. They just felt like they were just completely forgotten. Some people did think that, how do we help people to feel valued and really actually recognise them for what they're doing.
I think for me, I feel like I'm patting myself on the back here, but I think what comes out is how amazing the health workforce is, and that this is a really precious asset. You cannot replace the health workforce. It is highly skilled, highly accomplished. These were just really good people. They were normal people like all of us, and they told the most incredible stories, about their lives, about their professional lives, and you just get this sense of this thought of, wow, thanks. I'm, so grateful for these people who I work with. They're fabulous, and we need to value them and care for them long term.
That's a wonderful note to finish on, and I concur completely. We are so appreciative of the health system and healthcare workers at all different levels, but very rarely do we actually express that. So I think it's something for us all to be very conscious of, and it's becomes something that we just becomes part of the norm, so that all of those workers know that they're seen and heard and valued, and the leadership is trained to support and acknowledge those workers, so that we're prepared for the next crisis. And as you say, Marie, this won't be the last. Thank you all so much for coming.